You're watching the Wellness Hour Live. I'm Randy Alvarez. Today's topic, and this is for women with pelvic pain. According to my first guest, she says it may be misdiagnosed. So with us, we have Dr. Jeanne Stryker. Dr. Stryker, welcome to the program.
Hi, Randy. Thank you.
So, I said that at the top of the show. Is that true?
Yes,
That a
it
lot
is.
of women with pelvic pain? So where does a woman go when they have pelvic pain, typically?
Typically, you'll go to your OBGYN,
Okay.
and you'll get a pelvic examination, and then usually they'll send you off for an ultrasound examination, because with pelvic pain, you're thinking of fibroids in the uterus, or you're thinking ovarian cysts.
Okay.
And then secondarily, maybe an appendicitis, and then you're always thinking tumor as well. The biggest fear is ovarian cancer. So, pelvic pain or endometriosis.
Okay. So what's happening? So they go there, and what happens next? What's the next line of therapy? Because we're talking about what you do as an interventional radiologist.
So right at that point in time, you're still being a diagnostician. You're
Okay.
trying to figure out the diagnosis for the patient. And so then, they could go on to a CT or an MRI examination. And with pelvic congestion syndrome, pelvic pain caused by pelvic congestion syndrome, what it is it's an incompetent vein that's coming off of the ovarian vein. So the ovarian vein, if we talk about anatomy, the valve is incompetent. So
Okay.
with any, like varicose veins, you have incompetent valves, and there's reflux. And so with reflux, you have a buildup of more veins and more veins and more veins.
Because it's only going one way, it's not going back.
Absolutely.
Okay.
So there's an engorgement.
All right.
And so what we can do as an interventional radiologist is I can go in to the venous structure. I can go in through the neck and go down through the largest vein in the body, called the inferior vena cava, and then I can go into the ovarian vein, inject dye, and then you can see all those varicosities. You can go down further into the pelvis, and then what we typically do is we'll put coils in.
Like a stent?
No, coils.
Okay.
They're nitinol coils, and it causes thrombosis. So it causes an irritation on the lining of the vein, and it gets blocked. And then we can put this cetridocol, which is like foam therapy that you can do with sclerotherapy for those ugly veins in the legs.
So you collapse these little veins.
We close them off.
Okay.
Exactly. And it's more typical on the left side than the right side, but we interrogate both sides,
And the pain goes away?
and the pain goes away.
Okay, but how is it normally treated? Help me understand that. Because I guess there must be a way that it's treated now, and then there's the way you treat it, which is what you just said. So how is it normally treated?
So it really is a big misdiagnosis. A lot of times the pelvic pain, there is no diagnosis unless the OBGYN or primary care doctor orders a CAT scan.
So unless they could see a mass, there's nothing.
Correct.
Is that correct? Is that
Well,
right?
no, you'll see a bunch of dilated venous structures.
Okay.
So then it's up to us as a radiologist to pick up the phone and say to the OBGYN, hey, this patient has a lot of pelvic varicosities, and we can do this procedure to help the patient out.
Okay.
And so you're hoping that the OBGYN will convey that to the patient.
But how is it normally treated?
Normally, the
woman
surgery.
walks around because there's no tumor, there's no mass.
Surgery.
Because it's a vein problem, they may do surgery?
Yeah, it's just like when you have varicosities in your legs, remember?
Interesting.
People used to do the vein stripping.
Yeah.
So the same thing, you'll do ligation of veins, but that's a surgery that you undergo.
A couple days in the hospital? A day in the hospital?
Probably a day in the hospital.
So
Then
they,
you're
so
up
they
for 6
surgically
weeks.
just remove the veins?
Yes. Cut,
But
ligate.
that works. Is it more down? So you're saying rather than cutting them out, just go in and collapse them or dissolve them?
You go in and you collapse them, because here's the cool thing. I
Interesting.
can get my catheter way in there, and I can see, because they can even be involving the buttocks, the labia, and so you can get way down in there and cut off the blood supply. You can collapse those veins.
But if they both work, both approaches work, is that correct? Is yours just less downtime?
Mine's less downtime,
Any other advantages?
and it's more specific. It's really targeting the area concerned, because you could miss it. You could cut off, you can get rid of the ovarian veins, but you can still have tributaries that are causing the large varicosities in the labial region or the buttocks.
Does one pay more to the hospital than the other? I'm just curious, reimbursement wise?
I don't know the answer to
The
that
surgical,
question.
you're not sure? So why are, okay, so are there any statistical information that what you're doing is more effective than the other?
Yes.
You do?
Yes.
So
And
without giving those exact numbers, which one has a better success rate?
doing the ovarian vein embolization.
That's what you're doing?
Yes.
Going in there and collapsing veins?
Yes.
Interesting.
And the other thing that we found associated with that is IBS, irritable bowel syndrome. There is an association with irritable bowel syndrome and the pelvic varicosities.
Okay, interesting. Okay, so early intervention. Okay, so there's certain people that they have this pelvic pain,
Yes.
but it's tolerable. Okay, so those are people maybe that are turned away because they don't want surgery. Are you saying those people may be candidates to go in
Absolutely.
earlier?
Yes.
So earlier treatment.
Yes.
Interesting.
And those patients who have the pelvic congestion are also those patients that have the varicosities in the legs.
Interesting. Okay. So what do you want people to know? Is this one of those things that frustrates you or drives you nuts?
It doesn't frustrate me. And I just think that if you have pelvic pain, you know, there's the most obvious ovarian cysts, fibroids, but always think about the pelvic vein congestion and that we could intervene with minimal downtime. Minimal downtime.
So right now they're going to their OBGYN. Is that correct?
Yes.
So you're saying to say to the OBGYN, I don't want to put words in your mouth, to say, hey, can I see an interventional radiologist?
Yes.
Is that right?
Yes.
Do all interventional radiologists do this type of procedure?
Yes.
And so you rely on referrals. But the patient, could the patient pick up the phone and call an interventional radiologist first?
Absolutely.
Does insurance cover this?
Yes, it does.
Interesting, but it's not being done.
It's being done in certain institutions. It's just a matter of getting the word out and creating more public awareness.
But by far, would you say it's like 80% are doing the other surgery first and 20% are doing this other one first?
I don't know statistically.
But is it more often that they do this other surgical procedure?
It's more often.
Okay. So you think as women know about this, could anybody argue with what you're saying, by the way?
I'm sure they can, but you know, I'm just.
I mean, could somebody sit here, another doctor, and say that what you're saying isn't proven, or
No, they can't
not
say
enough
that.
literature on
They
it?
can't say that because the evidence is right there. Patients are getting better. It's not anecdotal. Patients
Okay,
are
good.
getting better.
So the downtime with the other procedure that's being done when you have pelvic pain, the surgical procedure, right, that strips out the could be 6 or 8 weeks. Is that
Correct.
true?
Yes, it is.
Because you can't walk, it hurts?
Yeah, you're having major surgery.
And this is like 24 hours?
24 hours.
Is that right? Have people ever gone to work the next day, even though they're told not to?
Yeah.
Maybe?
Yeah.
Is that right? And so see your interventional radiologist, and if you have pelvic pain. So there's no downtime. Insurance covers this. And and who do they tell? Their primary care physician?
Well,
To get a referral to see
I mean,
somebody
again,
like
you want to go to your OBGYN or your primary care
Okay.
doctor because you want to rule out other causes of pelvic pain. But if you see a lot of pelvic varicosities, and say to the patient, there's a couple options here. We can do
Okay.
nothing, we can do surgery, or we can do the ovarian vein embolization.
Interesting. Oftentimes do they wait because I guess most people don't want surgery, right?
Right.
So they wait because you just may have a small cluster of these veins.
Mm-hmm.
They wait until it becomes a big problem. Women can't take the pain anymore. Then they get the surgery. You're saying go in early, and they could go in, simple procedure. They go in, you collapse these veins, and they walk out of there.
And they walk out.
Is that right?
And the same thing for men, Randy.
What's the diagnosis called when a woman hears this, that they have these varicosities?
Pelvic congestion syndrome.
Pelvic congestion syndrome.
And with men, it's called spermatoceles.
Interesting. Is it less common in men?
It's actually very common in men. And so if you felt like a bag of worms in the scrotum, that's called a varicocele, or spermatocele. And we could do the same exact thing with men. You just go into the gonadal vein, and you cut off those varicosities, and they no longer have that bag of worms. And there's also a slight, with varicoceles, they have an increased risk of infertility. And they say that you may actually improve infertility with doing this procedure.
So they walk out the other way, right? This way you're talking about. The other one, does it require hospital stay? Do you know? 1 night, 2 nights?
I'm not sure with the urologist. I think they probably do either same-day surgery or an overnight, because they are making an incision.
Okay.
But it's an incision into the scrotum to remove that. You're ligating the veins.
Wow. Okay. Well, Dr. Stryker, always a pleasure to have on the show. Very interesting. Ask for a second opinion.
Ask for a second opinion.
And it shouldn't be insulting to the doctor. Just to say, hey, can I talk to an interventional radiologist?
Do I have other options? Is there other options for me?
All right, good. Well, I want to thank you for coming on the show. Always
Thank
a
you so
pleasure,
much.
Dr. Stryker. You've been watching The Wellness Hour Live. I'm Randy Alvarez. We'll be right back.